Good morning, everyone. Speech therapists traditionally have a rehabilitative role with our patients, but with an aging population, more focus has now been shifted towards palliative care, which is essentially how to live better towards the end of life. The role of speech therapists in palliative care is also evolving and becoming more significant. According to an international survey with 322 respondents, which was done in 2015, the role of ST in PC is as highlighted on this slide, and this was agreed by the respondents. However, they also agree that this area of practice is under-resourced, under-acknowledged, and poorly developed. Dysphagia management in patients receiving palliative care, it's inevitable because dysphagia is so prevalent in this population. In a study of 164 patients receiving PC, the incidence of swallowing problems was as high as 79%. Among the management strategies for this population, comfort feeding can be an option. According to a guideline that was published in Ireland, comfort feeding is individualized and should avoid negative connotations. This was supplemented by Lambert in 2012, saying that the primary goal of comfort feeding it's not necessary to reduce aspiration risk, but to ensure comfort and support the patients and or the family's wishes. So as we can see, speech therapists definitely have a role in palliative care, but how is it being implemented locally? And as a frontline clinician, we're seeing the term comfort feeding being used more and more often in medical notes. However, it's everybody using this term in a consistent way. As you can see here, the one on the bottom left-hand corner, it's using comfort, careful hand feeding because the patient has repeated aspiration and has refused rush to feeding. The one on your top right-hand corner, it's indeed a patient receiving end-of-life care, but it's being recommended to see us for comfort hand feeding. And the one on your lower right corner, the patient's family expressed their wish that they don't want rush to feeding and agreed for careful feeding. All these differences in terminologies and perhaps the different understanding of the underlying concepts got us wondering if comfort feeding, although being used commonly, it's aligned among professionals or not, none or not. This was how this study was formulated. The aim of the study was first to collect information from speech therapists on their understanding and roles in working with patients undergoing palliative care. Another aim was to understand the current clinical practice of comfort feeding. And the third aim was to collect some more ideas on how we could move forward with this field. With the information above, we hope not only to have a better understanding of the current situation, but it could also help to form the basis of preliminary recommendations in dysphagia management in the concerned clinical population. This survey was done online. I think some of you in the audience may have helped to fill in the survey as well. It was done in February to March this year. We had 38 responses, which corresponded to a response rate of 54%. The main years of working experience with patients undergoing palliative care was 5.4, and most of our participants worked in acute inpatient and outpatient services. A smaller number also worked in the community, and this is a very important area and up-and-coming area because of the upcoming ST service in residential care homes for the elderly, which is going to be in place real soon. So first of all, questions on palliative care. Our participants agreed to the definition that we put forth by the WHO, and the majority also showed strong agreement towards the statement that speech therapists have a role in both communication and swallowing or feeding problems. For the involvement in the actual care, all of them were involved in feeding and swallowing, and also a large number was also involved in education, presumably with patients or their families. Although most agreed that, from the previous slide you can see, most agreed that communication is an important aspect of our role, but only less than half of the participants were involved in communication management, and even fewer were involved in saliva management of these patients. And in terms of the level of comfort in working with individuals receiving palliative care, our participants were much more comfortable working with adults than children, as you can see on the left hand side, and they were more at ease when performing feeding, swallowing, and communication management as compared to oral hygiene and saliva management. Then we shifted our focus to clinical decisions for patients under palliative care management. We asked our participants if they would typically recommend instrumental assessment, which could either be BFSS or FEES for this group, and about a quarter say they would, with reasons such as the instrumental assessment results being supportive evidence to help decision making, but the majority say they would not. Some pointed out that it would not change how they manage the patient anyhow. For active swallowing therapies such as neuromuscular, electrical stimulation, the results were more lopsided. Most would not perform this, as some say that this would not be the main focus for these patients at the terminal stage. But on the other hand, compensation was commonly used by therapists because some say that it might help to reduce aspiration risk. The second aspect of our survey was on comfort feeding. First, we asked now if our participants agreed to the definition as provided by PALSAC in 2010, and the majority of them agreed to this statement. For terminologies, if you remembered in the previous slide that different people were using different terms to refer to sometimes same or different things, the participants mostly came across comfort feeding or careful hand feeding, while some also came across oral pleasure or quality of life feeding. Another point to note is that almost all of our participants have faced a situation where patients or relatives refused to follow recommendation of a non-oral feeding recommendation, which was made by speech therapists in a non-PC population, and this was wrongly referred to as comfort feeding. In the actual working environment, comfort feeding, it's either recommended through a mutual decision between the medical team and the speech therapist, or the medical team alone. Another operational conundrum is who would actually be performing to be feeding the patient, and you can see there's a overwhelming reliance on the family, while about less than half of the participants reported that either the patient care assistant or nurses would be feeding the patient, and 5 of our participants reported that there are no designated person in their workplace to feed the patient. Then we asked our participants what would their fluid and diet recommendations be if the patient showed aspiration signs across consistencies. You can see that the results are quite mixed. For diet, half of them would recommend soft, minced or congee diet, while some would recommend fluid and some will not even prescribe diet. For liquid, about half will recommend thin liquid and about 40% will recommend thick liquid, most of them without particular preference on what type of thickener they would use. The last few questions were about the current situation and the way forward. More than half of our participants had a multidisciplinary team in their workplace, but only 26 of them have ST on that team. And most of our participants, 79% of them, were not satisfied with the current situation. we further asked that, what were the barriers and the potential challenges? Top of the list was lack of resources and limited consensus among STs or other professionals, and legal considerations were also considered as a barrier in over half of our participants. And nearly all agreed that a guideline development will facilitate this, while the education of our role in palliative care is equally important. So these results show us that STs primarily agree to the big picture that about what palliative care actually is and what comfort feeding is. However, although there is a consensus of what we should do, we're not doing what we believe we should be doing. And from the results, less than half of our participants are involved in oral hygiene and saliva management. As Pollens has suggested in 2012, one of our roles is to optimize the function that is related to dysphagia symptoms, and I'm sure everyone here would agree that oral hygiene and saliva management is a vital part of this. Thus, we think that speech therapists should be more actively involved in these two aspects, apart from isolated feeding and swallowing management. It should be a part of the overall feeding and swallowing management. And for comfort feeding, the definition and the use of this term should be done with caution. From the results, we can see that it's currently being used quite loosely, even applying to patients that are not receiving palliative care or end-of-life care. And for clinical decision, although our results show that instrumental assessment and active swallowing therapy are not favored while compensation is, there's no actual evidence to support what we're doing or not doing. We don't have a concrete answer at this stage to how these clinical decisions should be made, but the principles of palliative care, which is focusing on patients' comfort and their wishes, and not solely on aspiration risk, should be adhered. And for the diet recommendation, again, our results showed us our participants obviously try to strike a balance between safety and quality of life. But I would like to draw everyone's attention to two recent studies with regards to recommending fluid. One is an animal study by Natives Zelza that was published very, very recently, which showed that pulmonary complications were more serious when the lungs of rabbits were infused with thickened liquids by starch-based thickener compared with gum-based ones, and the survival was the best for those that were infused with thin liquid compared with thickened liquids. And in fact, a recent Cochrane review also concluded that long-term effects of thick liquids in dementia patients were uncertain. So obviously, we can't only consider whether the patient chokes or not, but also the consequences of such in this fragile population. And in the way forward, more resources are definitely needed for patients and clinicians. Guideline development has one of the most pressing needs. We recommended that in a clinical guideline for speech therapy management in palliative care, in the palliative care population, the multidisciplinary team approach should be advocated. Our roles and expertise, including saliva management, should be clearly defined. And the operational and also the clinical aspects should be included as well. And obviously our study had its limitations. First of all, it's a local study, and our participants were also confined to colleagues that were working in hospitals. With the no surface delivery model in place for residential homes, clinicians working in those settings should also have the knowledge in working with patients receiving palliative care. And last but not least, this was a survey involving speech therapists only. Our goal is to have a second phase of this survey and collect information from other disciplines, such as doctors and nurses, on this issue. Our team would like to thank Mr. Daniel and Ms. Lucy Ho for the initial review of the questionnaire. And here is a list of our key references. Thank you.